The notion that failure of mandibular anesthesia is often associated with inferior placement of the needle has led to injection techniques in which the needle is inserted higher within the pterygomandibular space. The most successful of these is the technique developed by George Gow-Gates. The target for the Gow-Gates injection is the neck of the condyle, just below the insertion of the lateral pterygoid muscle. In contrast to other intraoral nerve block techniques, this point is at least 1 centimeter away from the nerves of interest. Therefore, medial, anterior, and inferior distribution of the anesthetic agent within the pterygomandibular space is essential for anesthesia to occur.
The Gow-Gates injection is the closest intraoral technique to a true mandibular block. In addition to the inferior alveolar and lingual nerves, the buccal and auriculotemporal nerves are often blocked, the buccal nerve approximately 70% of the time. The position of the operator and patient for performing a Gow-Gates block of the right mandible is similar to that used for the standard inferior alveolar nerve block, except that the clinician must be able to view the patient's face in addition to the oral cavity. The Gow-Gates technique relies on extraoral landmarks to establish the plane of insertion. With the mouth wide open, the angles of the mouth, the lower border of the tragus, and the neck of the condyle lie in the same plane. The needle is advanced in this plane just medial to the deep tendon of the temporalis muscle and through loose fatty connective tissue until it strikes the lateral neck of the condyle. Perhaps the most challenging aspect of this injection is determining the proper angulation of the syringe within the plane of insertion. According to Gow-Gates, the lateral flare of the tragus parallels the proper orientation of the syringe. Normally, the barrel of the syringe is placed over the contralateral canine. For a tragus that lies flat against the face, the syringe will be located anterior to the canine. With a divergent tragus, it will be posterior to the canine. The patient is requested to open maximally for this injection. External landmarks, the angles of the mouth, and the inferior border of the tragus are visualized, and the plane of insertion identified. The flare of the tragus is also evaluated to determine the angulation of the syringe within the insertion plane. The cheek is then retracted with the left hand. For convenience, the thumb may be placed on the anterior border of the ramus. The index finger may then be inserted in the intertragic notch and thus behind and lateral to the condylar neck to provide a tactile target for the needle.